We are delighted to welcome Dr. Jabeen Fayyaz, an Associate Professor of Pediatrics at the University of Toronto and a Pediatric Emergency Medicine Physician at the Hospital for Sick Children, Toronto. She served as a Medical Director of SIMS Kids Simulation Program and the Teaching Scholars Program at the Sick Kids Learning Institute. Dr. Jabeen Fayyaz is a global leader in simulation-based medical education with extensive experience in developing low-cost, sustainable simulation models and virtual training programs. She has led numerous international initiatives focused on faculty development, pediatric emergency care, and the team performance, contributing significantly to improving clinical skills, patient safety, and medical training quality worldwide.
Thank you so much for the kind introduction. And thank you, everyone of you who have taken time today to talk about this important topic and what is the intent in next 45 to 50 minutes is to provide you some insight, some foundational concept about the simulation-based education. Or frankly speaking, it's a conversational. I know a lot of time I will be talking, but please stop me if anything comes up in the middle. Otherwise, we will try to take some questions towards the end. And what I named today's my presentation is how simulation is acting as a catalyst of transforming medical education. And I will provide you some of the examples, some of my insight that the work which is happening in resource like a little bit resource rich spaces, and then what can happen in resource limited setting as well. So let's deep dive into, you can see this in the picture. This is the building in which in the first level we have our sim center. These are my amazing sim team, and I will show you more about my sim program later into the slides. So what today we are talking is what is simulation, what is simulation based education, how simulation act as a catalyst not only for education but also for quality improvement. Because हम क्यों मेडिसिन पढ़ रहे होते हैं, अल्टीमेट हमारा एम होता है कि वी विल प्रोवाइड द सेफ एंड बेस्ट पेशेंट केयर to our patient and be safe. So it is very interesting that there's a big shift of simulation happen from its role from in teaching and learning to quality improvement, and then some case studies. I would always acknowledge all the teams. I could not be able to do it by my own. So it is a combined work, whatever I'm presenting from my SimKit Sim team, my pediatric emergency medicine, ED, QI teams, etc. These are some of my disclosures. So just dive in. Traditionally, if you look back, if I look back into my training, how I am trained, how it happens that learning any new skill, whether history taking, whether passing an IV line, whether learning how to intubate, we have to wait if that patient comes up in our shift. Like अगर मैं first अपना न्यूबॉर्न इंट्रैक्शन देखूं या इंट्यूबेशन देखूं या आईवी लाइन देखूं, हिस्ट्री टेकिंग देखूं, तो देन इट इज़ लाइक if the patient comes up in your shift, then you will learn. I always quote this scenario that I was doing in my third month of house job, and then at around 2 a.m. I receive a preterm baby. I was at Civil Hospital Karachi. You know that sometimes nurses or sources, manpower are not available. And it's my third month and a preterm baby. It was a kind of a डीजा व्यू फॉर मी कि कैसे मैं आईवी पास करूंगी, and then the baby become apneic while we were managing in couple of hours. I started bag mask ventilation. I do not know much about intubation, but I tried, and I keep on providing whatever I can do. But in the morning when my senior came in, I was crying. This was my first interaction with a baby who is very sick or about to die. And then I know at that time my senior tried to console me, saying, no problem, don't cry. You have done whatever you can do. But then, see, you are so lucky that you are able to practice intubation on a preterm babies, and people don't get this opportunity for months. I know it is a good way to phrase or de stress me at that time, but now when I reflect, I always ask whether it is safe for me as a learner to be in that situation, or is it the best care really I provided to that baby? So that's how the role of simulation comes in. That is uh, like even हम कोई skill driving सीखते हैं, we have a car which is being geared toward learning, like brake or accelerator instructor के पास उसकी access होती है, and then he will make us learn. So जब हम एक ड्राइविंग और छोटी मोटी स्किल्स के लिए हमें सिमुलेशन की ज़रूरत होती है, तो why not for profession like medicine, where we are dealing with situations which are very tough, and we need more practice. So that's where the role of simulation comes up, where simulation turns the practice into mastery learning and keep us prepared, that we are ready to be in any or every situation. And this is what we do through SimKit simulation program. Now coming to the point, what simulation is. You will hear a lot of things about what simulation is. Some will say it requires expensive equipment, it requires the full space, mannequins. Simulation, sometimes people say, is a drill, learn how to do some task. But if you look at the modern definition of simulation, which is given by David Gaba, who is considered as a godfather of a modern simulation. So it is very important to, like here, I want to focus on a couple of words. That simulation is a technique, like competency-based medical education, problem-based learning, case-based discussion, didactic. These are all methods how to educate. Similarly, simulation is also a method. But yes, it is sometimes heavily dependent on technology. And what does it do? It replace or amplify real experiences with guided experience. So the first important term here is it is a technique. Second important term is it replaces the real experiences with guided experiences. You can control what information you are trying to provide to your learner. And then it evoke or replicate substantial aspects of the real world in a fully interactive manner. So this is a modern definition of simulation. And if you look at it, that you can simulation based learning, you can teach anything like medical knowledge, teamwork, communication, or even system improvement. You can test your system as well, that whether a policy is working, whether a guideline is working, whether your environment is ready to provide the care that you are intending to provide. Coming to some of the foundational concept, the first is mannequin. If you look at what a mannequin is, so mannequin is a human size or life size simulator representing a patient for healthcare simulation and education. It could be full body mannequin, it could be a partial body mannequin, and it can provide varied level of physiological function and fidelity. And we will talk more detail about fidelity in the next couple of slides. Some can blink, some can provide you heart sound, some can provide you lung sound, will show many other signs. Then coming to the task trainer. Task trainers, as the term define, are designed for practice and repetition of clinical skills. The difference is they are less costly, they are rugged and durable, and you are able to do the skills again and again and again. And you can see some pictures. This is a task trainer for IV or IM. This is a suture task trainer, lumbar puncture task trainer, and airway task trainer. Then the terminology which you will hear is simulated person, which is equal to, like you have heard, more standardized patient. But in simulation, we use simulated person. because in simulation you use a confederate or some people who are embedded participants, where they will play a role of a parent, of family member, or even a healthcare provider like a PICU doctor or any other. So anyone who is not a learner in the simulation is called a simulated person, and when that person is a patient, then it is called a simulated patient. Hybrid, as the name indicate, is the combination. For example, in the first picture, in the upper left-hand side of mine, you will see the simulated person as a mother and the child is a mannequin. Here again, the lady is a simulated person, and then there is a task trainer for the physician to practice giving IM injection. And here is mother is the pregnant lady, and the giving birth is a task trainer with a mannequin of a newborn baby. So hybrid. Then with the new technology, you will hear the virtual reality and augmented reality. I will not go into more definitions, but I will tell in a very simple languages कि for example, अगर मैं आपको glasses या कोई भी gadget दे दूं जिसको आप पहन कर for example हमारे सिम सेंटर में आ जाएं, तो आपका अपने सेमिनार रूम से कोई कांटेक्ट नहीं रहेगा. Now you are, by wearing that glasses, you are in an environment which represent our emergency room, our theater, or our simulation room, and you are doing scenario inside. So you have no contact or connection with your actual environment. That is called virtual reality. Versus augmented reality क्या होता है कि अगर आपने कोई भी gadget use करें screen based या glasses, and then you are still in your environment. जैसे आप इस picture में देखें कि the lady is holding a phone, and when she is taking a picture of the lane where she's standing, it get highlighted कि where is hotel, where is ATM, and where is the parking, etc. And in the medical context, for example, this person wearing the glasses is doing a CPR, and while doing the CPR through the glasses, she's able to see that how the heart is pumping, how the blood is flowing. So this is called augmented reality or mixed reality अगर आप कहें तो it's a combination between the virtual reality and augmented reality. और अब जो recent trend आ रहा है is a trend of either mixed reality or augmented reality, because as healthcare providers we cannot be like, अगर आप किसी भी environment में देखें तो it's very difficult to be detached from your actual environment जहाँ patient नहीं है, equipments नहीं है, and everything is virtually, and you are just doing some actions in the air, and no other person can understand. So the more and more popularity augmented reality and mixed reality is gaining. Then you may have heard about simulation fidelity a lot of time, and it is also conceptualized as well. हर किसी को लगता है कि fidelity का मतलब होता है realism, that how much realistic you can create the environment, so जब learner उस environment में enter हो उसको लगे कि वो इस environment में है. और हम इस सिमुलेशन फिdelity को हाई कॉस्ट और हाई टेक्नोलॉजी मैनिकन के साथ कंफ्यूज कर देते हैं. हमें लगता है कि हम तभी हमारी सिमुलेशन हाई फिdelity होंगी जब तक कि हमारे पास कोई हाई फाई मैनिकन्स नहीं होंगे जो कि बोल सकते हैं, जो कि ब्लिंक कर सकते हैं. Yes, they will help in increasing the fidelity, but then fidelity have a more broader concept. So yes, the high fidelity mannequins are high technology mannequin, but they are not the one only thing that will increase your realism. And I'm going to show you what I meant by that. For example, the first fidelity is physical fidelity. And what is meant by physical fidelity? जैसे आप ये mannequins देख रहे हैं, तो ये mannequin देख के आपको क्या लग रहा है? Is it a child or adult? So I know Mike आप लोगों से दूर है, तो it looks like a child ना. So it could be it's, and this mannequin is looking like a pregnant lady. So physical fidelity, how things are appearing. But then mannequins are only part of the fidelity. You can see the whole room is a part of physical fidelity. इस रूम को देख के आपको यही लग रहा है कि या तो ये एक पेशेंट केयर रूम है, या फिर हो सकता है ओआर का रूम हो, सॉरी लेबर रूम का रूम हो, या फिर इमरजेंसी रूम भी हो सकता है। तो इट इज़ बेस्ड ऑन कि आपका रूम का सेटअप क्या कैसा है। अगर आप इसको एक डेंटल चेयर पे रख दें तो फिर आपको होगा कि हाँ भाई ये एक डेंटल रूम है। तो फिजिकल fidelity mannequin play a very small role. The physical fidelity is the physical outlook of the whole setup, and then the medication, your blood product, and all other things comes into the physical fidelity. That's why it's very true that none of us throw away any of the expired medication. Even these yellow, this is can be created by adding a yellow color to your saline. The blood can be done by adding a red color to your saline as well. So it's all about the physical fidelity, about mannequin, about the space, and about the other aspects of simulation, how realistic you make it. The second is conceptual fidelity. Conceptual fidelity is the run of the scenario. Is the scenario is making sense or not? For example, अगर एक patient respiratory distress के साथ आ रहा है या respiratory failure में जा रहा है, तो then the saturation, heart rate, the progression of the patient represent an actual progression. ये नहीं कि patient respiratory distress में है, severe में, and the saturations are 99%. Yes, it could be 99% in the beginning, but then it should deteriorate if the patient deteriorate. So conceptual fidelity is the run through or the realistic scenario or realistic patient progression. And the third is psychological fidelity. Psychological fidelity is about the humanism part of it. Like अगर उसमें कोई stressful situation है, एक patient anxious है, definitely in pediatric patient is the parent who can portray that psychological fidelity. So the fidelity is a combination of physiological, conceptual, and psychological fidelity. And then all combined will result in the realism. But remember the David Gaba's definition that we will try our best to mimic or amplify the real experiences with the guided experiences. हमेशा ये बात आती है कि real patient जो हैं वो सबसे realistic होते हैं. That is the highest fidelity, your interaction with the patient. तो हम ये नहीं कह रहे simulation based education में कि that you are going to replace the experience that the learner is getting with the real patient. That is the highest fidelity, to talk, to examine a real patient. What we are saying that they need to be prepared well to be ready for that interaction with the real patient. और हम उसके लिए सिमुलेशन को यूज कर रहे हैं। तो इसलिए कभी कभी ये आर्ग्यूमेंट आता है कि ठीक है ये तो डॉल्स हैं या ये प्लास्टिक मैनिकिन्स हैं, वो कैसे रियलिस्टिक लग सकते हैं। उसमें आर्ग्यू करने की ज़रूरत ही नहीं है। यस, वो रियलिस्टिक कभी भी नहीं लग सकते। जो आपका इंटरेक्शन पेशेंट के साथ होगा, जो आप पेशेंट को एग्जामिन करेंगे, जो वो उससे क्यूज मिलेंगे और जो उससे फील आएगा, वो कभी भी सिमुलेशन से 100% नहीं आ सकता। लेकिन आप उनको सेफ लर्निंग इन्वायरमेंट में प्रिपेयर करेंगे सो दे आर वेल prepared to be ready for that interaction as much as possible. Then a term comes up as moulage. What is moulage? I would say in a very simple language, it's called makeup. So moulage is to create that realism. It's one of the avenue or one of the tools by which you will create. So it will set the stage for the simulation scenario. It enhance the assessment opportunities, support decision making, and improve your differential diagnosis by providing a meaningful clues to the patient condition. And then it also engage all senses in the learning experience. For example, अगर आप ये pictures देखें तो आपको पता चल रहा है कि ये burn है, ये stab हुआ है, यहाँ पे कुछ laceration है. तो I do not have to tell you कि क्या नजर आ रहा है या क्या, depending upon the scenario. The moulage can be done on the mannequin or moulage can be done on actual patient as well. And these are some of the examples. There's a whole moulage trainings and moulage workshops that you can learn how to create. These are all created by like self. We create it all by ourselves in the sim center, and sim programs are very much capable. They are not very difficult to do. Then come to some of the resources. I would like you, if you have your phone with you, if you can scan the barcode. This is a healthcare simulation dictionary, and why it is important to know these terminologies and these basic concept is similar thing that we need to be on the same page. अगर मैं कुछ mannequin कह रही हूँ तो you will understand the same thing. If I'm saying mulaj, then you will be able to understand. So if you want to have a same language and or the place where you will learn the truth is the healthcare simulation dictionary, and we all as simulation educator have it on our desktops, on our laptops loaded, and we always refer to it whenever we have to look at something. The other resource which you need to have are the in Excel healthcare simulation standards of best practice. I'm sharing my experience, and but it is all based on not that what I felt about simulation or simulation based education. It is with the standards, backup of the standards, and the Excel standards provide us best practices, and they are considered as a global gold standards for healthcare simulations. And if you look, there are, I think, 9 or 10 healthcare simulation standards, but at least these four, that is pre-briefing, debriefing, facilitation, and evaluation of learning and performance, are the minimum that we should all know who get involved into simulation-based education. And here is the barcode. If you are not able to scan the barcode, that is completely fine. I can send it later. And why adhere to standards? It will provide you evidence-based framework, it will enhance the engagement, and it will help you getting the leadership buy-in and organizational commitment. Then the question comes up, why we use simulation. I think you are motivated enough. That's why you are all here to learn about it. But just to give you more reinforcement that simulation provide us a risk-free environment where learner is allowed to make mistake and learn from those mistakes, and not to do it when they have an interaction with the patient. It is a better way to engage the learners in comparison to many other methods, and it's now proven, and there's loads of literature present there. We all remember that जब भी मैंने कुछ mistake किया है, I always remember it. So it's better that that mistake won't happen when you are providing care to the patient. It is better to happen in an environment where there is not a real patient, and then you will learn, reflect, and have an experiential learning. It also enhances the teamwork and collaboration. Like you can make a interprofessional or multidisciplinary teams and let them work together to take care of a patient, which usually does not happen very often. Like kitni dafa, at least back when I was trained, I was not aware that when I will started my house job, then I was much more cognizant that I cannot function or perform my work without working with my nursing colleagues, working without knowing the ward boys, without interacting with so many other specialties. So this you can mimic or you can create in simulation. It improves critical thinking, clinical judgment, and help you prioritize and communicate. You can control the types of patient experiences so that every learner is getting the similar experience. It's not कि अगर मैं lucky थी मेरे पास intubation आ गया, मेरे पास exchange transfusion आ गया, cardiac arrest आ गया, तो then I learn, and then the other learners have to wait till their shift have those kind of patient. No, you can train all the learner on the same scenarios and control the type of experiences and observe them and provide them feedback more closely. So I would always say think simulation as a sandbox. जिस तरह बच्चे sand में they create something, they don't like it, they recreate it, and then it will lead to sometime perfection. So similarly, simulation is a sandbox where you will help them carve their learning, and they will develop those skills and then apply those skills to the patient. Choosing type of simulation, I would say it is like these, there are many things that you have to consider, but at least these five things: that what is your learning outcome, what type of simulation best matches the objective. For example, अगर आपको उनको कार्डिक अरेस्ट सिखाना है तो फिर पूरा मैनिकिन की ज़रूरत नहीं है. You may have some torsos or CPR dummies and you can make them learn. इसी तरह अगर आपने कोई भी स्किल, लेकिन अगर आपको कोई सिनेरियो रन करना है कार्डियोजेनिक शॉक का, then you need a full mannequin, you need a full room setup, etc. And do I need to immerse the learner, and this is the same thing, or do I have to make them practice discrete skill? What level are my learners are and what are they capable of? तो ये नहीं हो सकता कि आप हायर लेवल स्किल्स जो हैं वो लो R1s को से एक्सपेक्ट करें. And then choose what best support the learning objective, learners, what are the resource available. अदर मिसकंसेप्शन जो बहुत इंपॉर्टेंट है कि हर कोई कहता है कि अगर सिमुलेशन कराना है तो आपको पूरा न्यू करिकुलम बनाना पड़ेगा. ऐसा नहीं होता. यू कैन स्टिल हैव योर एग्जिस्टिंग करिकुला, see where are the gaps are, what are your pain points, and then try to use as simulation to solve that problem or to bridge that gap. So for example, अभी आप let's suppose कार्डियोजेनिक शॉक एक लेक्चर के थ्रू पढ़ाते हैं, एंड देन यू विल फाइंड कि ठीक है, जब हम देख रहे हैं कि कार्डियोजेनिक शॉक आता है या कोई टॉफ का पेशेंट आता है या कोई भी कार्डिक इमरजेंसी का पेशेंट आता है, लर्नर्स आर नॉट एबल to perform this or not able to do certain aspects in a better manner. So just give them a pre-learning about cardiogenic shock and replace that with a simulation based session, so that 1 hour is replaced by the simulation based learning. So you do not have to create a new curriculum, you just have to integrate simulation into the existing curriculum, and that is the best strategy. And while you are doing that, these are the practical questions you need to ask yourself: that what is the institutional problem you are going to solve by this educational intervention. It's not that it is cool, it is in fashion, so let's do it. No, it's you need to have a problem that you are trying to solve because it is a resource intense methodology. What is the cost? How long? Who are the learners to whom this intervention are? And definitely you need to have the buy-in of your stakeholders or leadership for sustainability, otherwise it won't be sustained. One other concept that comes again and again and again कि भाई सिम कराना है तो सिम सेंटर चाहिए, और सिम सेंटर चाहिए तो बहुत सारे पैसे चाहिए. Very fair enough, but I would like to bring your attention that sim program and sim center are two varied entities. You still have a sim program without a sim center, but yes, sim center will help you to enhance your sim program. So sim program is a structured educational initiative which is like you want to use a simulation based framework in your curriculums. It is more learning objective focused and you will integrate into your curriculum. While Sim Center is a space which will provide you physical infrastructure, it act as a resource, and then there are some like kind of technology like mannequins etc will be made available through Sim Center. So the key difference is the program is more focused on the educational content, instructional design and delivery method. So it help in developing, or simulation program is curriculum development, developing learning objective, how would you assess the learning and how would you prepare your faculty. While center is an infrastructure and operational support, enabling program delivery by providing you physical facility, equipment maintenance, technical support, and keeping all the resource at a central place. So if you look at the SIM program, it is curriculum, faculty, and learner. And SIM center is space, equipment, technology, and the staff like which will help to achieve that. So both component need to work synergistically to achieve optimal learning outcome, but you still can have a sim program without having a sim center, and many programs everywhere globally started with a sim program and then they convinced the leadership to have a sim center available for them. So I will take a small break here if anybody has any question at this point. I know I'm talking continuously for the last 30 minutes, so just let me know if you have any question at this point.
Yeah, I think we don't have question right now, but at
Okay,
the end, we would like
sure.
to ask.
Sure, sure. And I might skip couple of slides because I created like a, this is kind of a big presentation, but like I will skip me some slides, but I would like to debunk two important myths which are about the simulation-based education. The first is simulation is costly and resource intense. Yes, it is costly and resource intense, but if we look at the cost of failure, if you look at, I know the medical legal system in Pakistan is not to the level where it is in other part of the world, but here when a medical error happen, then that cost of failure cost much, much more than the sim program and sim center, and we need to have that in mind that yes, there is no check, like there's not a lot of liability medico legally, but then we are, it is, even if we think that a failure in any care process will cost the life of a person, this is enough, I think, and we do not have to always think as a money as a cost. So if you look at the Helping Baby Breathe, which is a WHO program, which is very, very, like you can see the mannequins are very basic dummies. They filled it with water and then the training happens. And then today they are almost, it is implemented in 80 countries with 450,000 live birth attendants trained and equipped in those countries. And it has led to reduced neonatal mortality by up to 50% and the misclassification by 25%. So it is huge benefit. And if you match the cost with many other intervention, it was negligible cost. The other example is from Pakistan, the Indus Hospital Health Network. We have implemented this pediatric emergency medicine curriculum, and we know the resources are not enough, so we use our creativity and innovation, which we named as Jugaad, and we, what you will understand what Jugaad is. So Jugaad is innovation that bringing local context. So for example, these are the defibrillators that they created. These are the expired vials that they are using. These are some of the, with the gloves, they created some of the injury pattern. This is a cricothyroidotomy model that they created by simple gauzes, the ET tubes, and then this is a chest tube model that they created from the laundry basket. You can see the lateral canthotomy model that they created with the simple disposable cup and the golf balls. This is the intraosseous line model that they created with that this skin you can buy very, like very, very cheap ways, and they have created then again this is a lumbar puncture model by the clips that you use it, जो कपड़े सुखाने के लिए clips use होते हैं, and you can see that mimic the intervertebral areas, and then they created this, and some of them are now IPSS Inspire Simulation Fellows, and they are testing even the effectiveness of these low-cost models to learn skills like even central line. So you can see all these moulages that they have created. This is an ultrasound guided model that they created through a sponge and like a small straw, where they are learning through ultrasound guidance the how to access the IV axis. So these are all like cost-effective innovation that they have created. Then these are tabletop exercises for disaster management. This is by the Lego figures. Then these are some of the pictures, and this is the trainings that happened from 2018 since I'm working with them. So we have trained 500 interprofessional educators, interprofessional teams into basic emergency care, trauma care, and pediatric emergency care. We have trained 68 faculty members as train the trainer from all these places to run these curriculums into their own environment. And there were 28 local and international facilitators which were involved. Second big myth is simulation is just for resident and nursing education and teaching, but it's not true. We created this code silver active attacker policy, and then during the policy development at each stage simulation was used. That what should this policy should be, how does it work, how announcement will happen. Everything was done through simulation, and then the policy testing also happened through simulation. Another important example is the integration of the CPR coach role into the hospital resuscitation teams, which is a quality improvement project. And this is all the team members. We all know the CPR coach is now recommended by the AHA that we need to have a CPR coach when these events happen. So we develop this training and which are all simulation based. So let's watch this video.
Protected code blue 7B Bravo. Protected code blue 7B Bravo.
I am Jabeen. I'm the team lead. Can you please check the pulse and rhythm for me?
We don't have a, I don't feel a pulse.
Okay, because we don't have a pulse, let's start high quality CPR.
So this is an online training that we created for them to learn about CPR coach, and they come in person just to do a simulation based practice.
1 and 2.
I'm going to get you to compress and count out to 15, and then we'll do 2 breaths.
11, 12.
My name is Bhavin, I'm the CPR coach.
2.
If we could get a backboard and as well get the pads on to help to optimize high quality CPR.
Hi, my name is Laura. I'm the medication nurse. I'm gonna get the pads and the board ready.
Okay.
Hi, I'm Bess. I'm just behind you, and I can take over compressions at the 2 minutes mark or the next.
Okay.
14.
So maybe at the next breath, we can slide these in together if you want to do the board.
I'll do the board.
Okay.
6, 7.
So at the next breath, we'll slide under the board and put on the pads.
All right, here we go.
Okay, putting under the board.
Okay. And I have the pads on.
And let's
Okay.
continue compressions.
All right. The next breath will pass over. 6, 7. There we go. I'll go set up intubation equipment. 11.
Okay, so I'm watching for the rate here. We're going a little bit fast. We want to aim for 110 beats per minute. Great job. We're getting at 110 beats per minute. At the 2-minute mark, we can switch compressors.
So these are all created very simple. We bring our team, we record it, and we provide training. Then they come for in-person simulation training, and you can see the training evaluation summaries. They are rated very high. And then we looked at the parameters of our CPR coaches or CPR outcomes through the ZOL data, and we see that an improvement happened, and we are still continuing to evaluate that data. So this is an example that simulation-based teaching and learning can be used beyond just making them learn about some topics. It can be used for many other broader areas that you want to improve in your environment. I would like to spend very quick time about the learning because you all are from the education committee. You may be interested in learning what are some of the learning theories which back up this is Knoll's theory, which based on adult learning theory, where say that if adult learner perform a skill, they want to know right then and there. So did I do it right? Is there something I need to do differently? And then simulation provide the opportunity that once they have done something, they will get that feedback immediately. Second is the social constructivism, which tells that it is based on the idea that learner construct new knowledge whenever they do something, whenever they perform something. So like in facilitate, it's during simulation-based education, the facilitators always construct scenarios that help the learner to create new skills or knowledge. For example, if your first year, like your year 1 to year 4 can do the same cardiogenic shock, but for the year 1, your learning outcome or goals will be to differentiate between septic shock and cardiogenic shock. But for second year and then maybe later on in the fourth year, your goal will be how they can act as a team leader, how they can manage a difficult scenario of cardiogenic shock, how he mobilized the ICU team, and how he will make that patient go in a timely fashion to get admitted to the PICU. So that's how the same cardiogenic shock can be run from level year 1 to year 4 for junior and senior learner. Then this experiential corpse theory, which talk about that this is the circle, that they will have a concrete, like they will do a task or perform a scenario and then reflect on it, and then later on do the scenario again later, and then it will continue to be a learning cycle, which is kind of experiential learning, where you experience, reflect, you will learn, and then you will experiment it into the other. And then this is a very interesting theory where it talks about novice to expert. That is, you will pass from 5 distinct stages. That is novice, competence, proficient, expert, and mastery. And then it is very interesting that at the same time you will be novice at something and have a mastery at other thing. And it also goes with the concept that if you have been a physician or a nurse for 40 years but haven't started an IV in 20 years, then you may not be expert at starting IVs anymore. It's about the maintaining your competence, maintenance of certification, MOC you might heard. So even I am a staff physician, I have to go through simulation days every year where I will practice some of the skills and practice or run some of the scenario as team leader. So continue to maintain, because I am not performing as many intubation as much when I was a trainee. So this is a very important concept that you need to have been through this all cycles from novice to the mastery. Then it always come up that what are the other avenues that we can use. So some of the platforms which I will demonstrate very quickly, definitely it need the full sessions to learn about these platforms. But the first one is affinity learning that we are using as a pre-learning. Why? Because the scenarios are easy to author, fully customizable. You can access through your mobile devices, through your iPad, and through your phones. It will provide you clinical decision making, information gathering, and you can like create these kind of scenarios. You can ask knowledge inquiries by giving them a visual cue, a scenario. Like for example, here the knowledge inquiry is about a fluid. This is kind of how at the back end the scenario look like. You can ask them decision making opportunity, that everything is need to be happen, but what is the order? What need to be happen first? What need to happen next? Then it will provide you with the visual interaction that you will put, like for example, you have to ask the learner that what is the auscultation, and they need to select where they need to auscultate, and when they put their cursor here, it will provide you the audio of the lung sounds, and then you can make what kind of sound it is. If you have to orient your learner with the spaces, you can just take a 360-degree images, put a hotspot, and they have to identify what are the equipments, what is that space where you will be performing your procedures. Or if you have, like for example, I'm thinking cath lab, and you have to orient your team about the cath lab, then it can be used, even incorporated into those pre-learning. Then it has a responsive vital simulator, and it will, based on the scenario, you have to choose what is the best way. And then once they chose the right thing, the saturation or the vital signs get incorporated. It does have in AI capabilities where you can interact with the screen by either typing or by talking through the audio capabilities. Then it will provide you at the end the most important thing, which is we always need to know whether our learners did the pre-learning before coming to the session. So it will provide you the reporting and analytics as well, not about the completion, but about the right and wrong, what they have done correctly and where they were struggling, so that you can focus it more during the sim scenarios. So it is a very good platform. We are using it for almost now 7 years, and we found it very helpful. The second is the virtual resuscitation room. Virtual resuscitation room is mostly for the acute scenarios. It is freely available, developed by Sarah Fuhe and the James Lewing, who is my colleagues here in Canada. And we have at Sick Kids develop a lot of pediatric content. If you want to go to the virtual resuscitation room, this is the barcode again, but let me show the video. How does it work?
This is the virtual recess room. First, it uses Zoom. Zoom can provide the audio and the visual, so learners and facilitators can communicate with each other and mime actions like CPR and the all clear. The virtual environment is created by a Google slide. All the learners and the facilitators will simultaneously open up and enter the same Google slide document and make synchronous edits that are viewable pretty much instantaneously by everyone. I want to emphasize this. This is not a screen share. This is a collaborative document, so everyone can be simultaneously making changes like putting on monitors and putting on oxygen and typing in a text box, doing the same actions that you would do in the sim lab. This all makes more sense when you see it in action. Let's check it out. Begin by applying monitors. Learners apply monitors by clicking and dragging the image of the monitor into place over the patient's body. As this happens, you can see the facilitator typing in the vital signs in the text box of the monitor on the right-hand side. Next, get access. Place an IV by clicking and dragging the IV over the patient. Difficult poke, you can show how to do an IO by landmarking and then walking through the steps of the procedure. Assess the ABCs and examine your patient.
If I take a look at his face and airway, what do I see?
If you go to slide 4, you can see a picture of what his face and upper airway looks like. And if you press play, you can hear an audio of his upper airway sounds.
Thank you. So Marley, I see a little boy who is awake and alert. He has some obvious swelling around his mouth and a rash on his cheeks. This is what I hear.
Manage your patient's airway. Click and drag the oxygen into place on the patient's face, then choose your flow rate. To grab extra airway supplies, go to the airway tray on slide 3, copy what you need, and paste in place onto slide 1. Organize at the head of the bed like you would in real life. The patient's still hypoxic, you might set up high flow, or type in the settings you need to start BiPAP. If they need intubation, you can see what your view is on GlideScope. Give medications. Go to slide 2, your medication tray. Copy the med you'd like, then paste it in place on slide 1. Drag it into the medications given box to show it's in the patient. Use machines. You can cardiovert your patient.
So oxygen, I'm going to take it off.
Excellent. So are we all clear? Clear.
Yeah.
I'm clear, you're clear, the oxygen is clear?
Point of care ultrasound has been integrated. Look at the image and describe your finding. Do procedures. You can do procedures like this Craig by clicking and dragging pictures of equipment and then using landmarking lines to show where you would make your incisions as you describe your steps. Let's see it in action with the perimortem hysterotomy.
I'm just going to make another vertical incision, just like a nick with my scalpel, and then use scissors to open up the uterus.
We're at 2 minutes.
Work as a team, divide into roles, and communicate clearly.
So Sarah, if you don't mind giving 8 puffs of Ventolin to this baby and let me know once that's been done. And if you could auscultate and let me know if his wheeze has improved, that would be great.
And just confirming the Benadryl as well as the ranitidine and methylpred have been given.
Thank you so much for listening to me share the virtual recess room.
So, I know it is very low-key and the limitation is you cannot practice procedural skill, But yes, we have been using it for advanced pediatric life support scenarios. We are using it for sedation scenarios. It is being used on undergraduate, postgraduate, practicing physicians, and it really work very nicely. And it doesn't have a cost. It is very free. It is free to access and use. Then a couple of slides about our SimKit simulation program, and then I will end and take some questions. So our SimKit simulation program is right now a 11,500 square foot facility, which is kind of state of art in Canada, but we do not have it forever. From 2009 up till 2023, we have just 2 rooms, which we used to call our sim space, which are kind of a smaller, like one is the high fidelity room, and one was the debriefing, and one is the procedural skills room. So these are some of the pictures of our sim space. These are some of the mannequins. We do provide a lot of faculty development workshops. You can see there. We also provide support to, like, as a consultation on scenario development, tabletop exercises creation, in situ simulation, where the simulations are happening into actual patient care environment to see whether when we trained our teams, are they able to perform in the same way when they are in the actual patient environment. We do space evaluation. Always, whenever a new space is being planned, there is a simulation there to see how it is planned is going to work or not work. Then there is a light fellowship program where we provide elective, a certificate, and a fellowship program. If you are interested, I will provide you more details about it. We do a lot of immersive virtual reality and AI-based technology innovation. And if you look at the last year data, we have 53,000 learner, 897 sessions, and learning hours for 53,000 and 9,000, almost 10,000 learners. And you will see that the sim program, like these are the simulations that are happening into our sim center, but then a lot of simulation happen into actual clinical environment to test our environment. We do interprofessional and interprofessional, like multiple teams, like nurses, physician, RTs, social worker coming together and learning. An important point is almost 63% of the simulations, still the physicians or staff members who have been graduated are still doing the simulations for the maintenance of their competencies, etc. This is our sim team, and it cannot happen without a big team, but we do have like almost 4 or 5 members for many years, and this expanded over time. So like one thing which I want to show you is the capabilities like through 3D printing. You can imagine that through the 3D printing, we are creating that, like first of all, some models, and through mollaging, this is the example of the mollages that you can see how realistic they look. Then the 3D printing, we are creating some models which are cost effective. For example, a suturing pad, if you buy it from the company, it will cost you hundreds of dollars. But if you develop through 3D printing, it will be less than $5 or $10. And I'm pretty sure if you collaborate with the engineering departments or other universities, there may be a 3D printing capabilities available. We do a task trainer development. Like if there is no task trainer present, we will develop from scratch. And one of the example is the circumcision task trainer that we developed from the scratch. This is like some examples. This is the IO that we created through 3D printing. This is a nasogastric tube task trainer that we develop, and you can see the cost is $5.24. This is a POCUS simulator where you will have a probe, and then underneath the skin, you will put some RFID reader whereby when the probe goes there, the learner will be able to see the image. And it's if you go to the POCUS or ultrasound, ultrasonographic or echocardiographic trainers, they cost like at least $40,000 to $60,000, but this only costed us $120. This is a foreign, I think this is a port access task trainer that was created. This is a foreign body removal. This is a circumcision task trainer. In market, it was available $100, and then we created it into $1.20. This is an injection pad. It has costed us only $2. Respiratory ventilator resistor, which were created. Then broken bone trainer, which was created. These are the suture pad. This is cricothyroidotomy, chest tube insertion task trainers, which were created. So with this, I will kind of end my presentation. And at the end, I want to show like couple of things about the competency based. This is a competency based program that we implemented and developed. This is the article. We use the logic model to look at the impact and effectiveness of the mandatory competency. It had a very high, highly evaluated by the learners, and it also developed some leadership, closed loop communication, and CRM skills. So with this, this is the end. If you want to follow us at social media to keep updated what we are doing at SimKids, please follow us. This is our LinkedIn page barcode. Thank you. Assalamu alaikum. Take care.